Hey guys, welcome back to the Foam for App podcast. Tyler and Sam, and we have a cool episode. I had our senior director of education at LifeLink, Allen Wolfe, on, and we talked about how to implement ultrasound. Kind of the lessons learned through the different chapters of us implementing this on the helicopter. And obviously, it's always a work in progress. But that was how I wanted to frame this episode.
Yeah, I had a few follow-up questions for you on this. So one of the things that Alan was talking about was these minimum quotas that the clinicians go through. So they have to hit X amount for the year. So going into the new year, I was thinking, like, if I'm a clinician at LifeLink, like, how do I go from 0 exams to 1 exams, and like, what qualifies that? So if I'm a clinician, my quota just started over, it's January 1st, I go on a flight. Is that just a single exam? Does that count? So let's say that I just do a single view of the heart and I throw that into my chart. Is it like a checkbox to say, like, was an ultrasound exam performed? Or does it have to be something like more substantial where somebody did like an extended fast exam? And then I guess a tack on to that is, do you guys break those up as far as like minimum quotas for each? So you have to have so many like cardiovascular exams, so many maybe vascular assessments or fast exams. Like what qualifies that?
Yeah, so if I go on a call and I get let's just say January 1st, I go out and I get somebody who's in a trauma and I detect lung sliding or the absence of lung sliding, then when it comes for me to have to meet that quota, or what I have to go and basically do on myself or a partner to make sure that I'm touching this equipment, monthly, quarterly, whatever, then I don't have to do the lung sliding one because I already have that. So if I go on, but I still would have to do like a parasternal long, parasternal short, right upper quadrant. Just because I broke it out on one call doesn't mean I'm good and I don't have to meet the rest of those, because we have the specific exams to answer the various clinical questions. And so to maintain the proficiency and make sure you're not busting it out, twice a year or something like that, that's what we do. Is we get it out. Typically, we'll do it on each other, and then when we sync it up and we send it over to Protean, essentially we're just putting in, this was a test. This was for Tyler. This was my right upper quadrant, and that way you're just getting the reps in. It's the equivalent to somebody, when I first started at LifeLink, I would sit in the recliner and just scan all over myself, and look for different things. And it's just trying to get people to do that, the familiarization. Even when it comes to something like the fetal heart rate, we'll get our own heart rate, drop an M line down the, tricuspid valve or mitral valve or whatever, and actually go through moving the calipers and just that muscle memory to build that in.
Yeah. And the other thing that I thought was cool, so you guys do like delineate those a little bit, like there's kind of this amount of these, you can't like go through a whole year without performing this type of exam.
Exactly,
otherwise you have to like make up for it somewhere. And then so let's say that over the course of the year, a clinician, they do 100 exams, and you guys are talking a little bit about peer review, and then having an expert look at it, a content expert, and then there's also, it can graduate to the medical director. So if I'm a clinician and let's say I do 100 exams, like, first of all, is there when you say like peer review process, is that included into like the expert review, or is it like your peers are reviewing the largest percent, and then a certain amount of them go to the expert, and then like a certain amount of these go to the medical director, and it's kind of like attrition up the line? Or like what percent would you say of the exams are getting looked at by who, if you see what I'm saying there?
Yeah, so 100% of them are going to be looked at by the subject matter experts. And so then they can push those up the line to the medical directors to evaluate. So, the main thing, like, we mentioned in this, not to give it away, but like, could you answer the clinical question with that view? And that's the most important thing, because if you think you can and you turns out to be some terrible view, then that shows a fundamental misunderstanding in what we're trying to accomplish with that specific view. As far as the peer-to-peer type thing, that's not as common to look that up. It's a little bit more difficult to see that. We do critical care case reviews, and then when you present your case review, you'll also present your ultrasound as well. And so, and that's the same that goes for things like the CMAC, right? So we record every single intubation, so that way when we all get together and do these critical care case reviews, we can watch those back, and then we can have the ultrasound piece, and then throw up the 12 lead, and then put up a screenshot of the epoch. And so you really feel like you were on that call when you see all of those different components, as opposed to just looking at a de-identified run report.
Yeah. For the expert review, I mean, that's pretty crazy. Like 100% of those things get reviewed by an expert. Do you think that should be a pretty much like an industry standard for people? Or if you're a training officer or something watching this and you're thinking, man, how am I going to get 100? I guess you don't start with, every single person in the entire service. You kind of stagger this. Let's do one station and see how it goes or whatever. But I mean, if you have 100 people, I mean, how many content experts do you need to keep up with that? Just to keep the numbers round, like, is that one or two people because it's not, every single call? I'm just wondering about like workforce, like how many of these do you have to be like attached to an academic center where like there's people doing an ultrasound fellowship to do this? Or if you're not attached to, a hospital consortium or something like that, how do you get experts to review this stuff?
Yeah. So, and the experts are homegrown experts, right? So these are people that we've sent to maybe do some extra education. They've shown proficiency in this. When we established the baseline proficiency, like he mentions in this episode, and they're the ones who went right through it, scanned it. This is something that they obviously spend a lot of time outside of work studying as well. And so when you first launch a program, I would say you do need 100% reviews. You got to make sure that people are using it at the right time. They're training their brain to identify the things that qualify as a good view. And that doesn't mean, 100 people, that you're doing one for every single person. You look at your call volume, and if they run 2 calls a day or something like that, and they break it out maybe on one of them to answer a clinical question, it doesn't end up being that much. But I do think that that's smart to do, is to have certain people that excel. I don't know if you can do that right away, though, because when you first launch a program, implementing ultrasound in the pre-hospital setting, it's going to take people to build up a little bit, but you're going to have those that really attach to it. Just like when you have any service, there's always the guy that's really into the ventilator, or the person that's really into 12 leads, and so they kind of come to the surface, and you see who are the people that are more interested. And then that can take some of the load off of the QA, QI person. So that way they are not getting inundated with all of these ultrasounds that they have to look at. But that piece of tying the circle or closing the loop on it and getting that feedback is so important, because there's a lot of things in EMS that we don't get that on. And so finding those things, those little wins that we can, whether it be a CMAC recording, giving advice on laryngoscopy, or looking and being like, hey, next time make sure you can see the 2 rib shadows so you're not too close, or make sure you get that caudal tip of the liver. All of those things really help bring, I guess, the level that we're trying to accomplish with using ultrasound and very specific clinical questions. It's not like we're doing musculoskeletal blocks and doing all these crazy things with it. So let's just start off with a couple clinical questions. Let's just start off with lung sliding. And on traumas, we're going to break this out and we're going to look for lung sliding. And on cardiac arrest, we're going to look for cardiac activity. And then you slowly, as that, people do well with that, then you can keep developing that.
Yeah, I think it helps you've compared it a few times to reviewing intubations, right? And so if a service, I think that helps bridge the gap a little bit, because for a lot of people, it's going to be like this very foreign thing. Like all of a sudden we're doing this live imaging and there's these different views and stuff like that. But I think that makes it a little bit more tenable if you think about it like, okay, it's limited to this station at first. We're starting with this exam. We have this person to look at it, and you can almost think about it like implementing your first video recording laryngoscopy or something like that. And then I think it's a lot easier to deal with when you think about it. It's not every single exam that every single person is doing that now has to get reviewed 100% of the time, but implementing small pieces at a time probably makes it a lot more doable for services. Well, awesome. Yeah, it was a really good interview, and it's interesting to see things from the admin side and like a systems perspective, because I think that there's a lot of clinicians who are really excited about it, and then a lot of people who are in management being like, I don't know how we're going to do this, So these are good questions to answer.
Awesome. All right, man. Well, we're finally able to align our schedules. I was able to save up enough money to have you on the podcast.
True.
No, dude. So I have been in the process of thinking through, from a clinician standpoint, how I would implement ultrasound, right? And so I came to LifeLink. They already had ultrasound. It looked very different than how it looks now, but they already had ultrasound. It was in a case that was behind the forward-facing seat, and we were using, some software. I can't even remember the name of it, to go through and to do some QA, QI. And so I was thinking through the process of like what that looks like, because I feel like you have these two different ways of approaching it. And because the devices are so cheap now, you have this world where people buy them for themselves.
Right.
And they're like, yeah, I have ultrasound. It's like a stethoscope. Why do I have to get permission to use this? And then these images are sitting somewhere, not being looked at. They could be making the right decision. They could be asking appropriate clinical questions, but you really don't know.
Right.
And so there's that one. And then there's the company that's like, yeah, we want to adopt it because, it's a helpful device, but we're going to put it on the supervisor truck. And the supervisor is going to have to come out and do that. And then, I guess you could say the true way to implement it is how I believe LifeLink has done it now, with you and the education team looking over that and finding out, for one, baseline proficiency, but two, like, how do we make sure we're actually answering these clinical questions? And so that's how I was hoping we could angle this discussion, is somebody's watching this and they're like, yeah, we want to get it. We've had a lot of false starts. We have them. Maybe, I can't tell you how many times I've heard, I have a whole closet full of butterflies or iVis, you name the device, and we can't get people to use it.
Right.
Or there's not a QA, QI system. So when you look at where we were when you came in to LifeLink and like where we are now, and knowing that your previous program, I don't know if they used ultrasound or not. They didn't.
We did it all.
What would you say has been the most impactful, meaningful things that we've changed to make it to now where we feel more proficient with using ultrasound and we're actually answering important questions?
Right. I would say the biggest thing would just be a framework of quality assurance. That's the biggest thing. From other companies I worked at, like I worked at Air Methods for 10 years. I worked at MedStar DC for 20. Ultrasound, we didn't use in either one of them. One of the drawbacks from when people would say at Air Methods, hey, can we use ultrasound? The business people say, hey, we should be doing ultrasound. And physicians would say, QA piece is the biggest thing. Who's going to look at those images and validate that we're doing the right thing? How can we make proficient 1,600 people in ultrasound, over and over again? So that was the drawback, was always the quality assurance piece, was the fear that people would use it incorrectly and make the wrong decision, or not use it as an adjunct to help them make decisions. And,
right.
You have maybe a liability there. And so maybe soon they'll go that way. So when I came to LifeLink in 2020, you guys were already doing it. Part of the education piece is looking for the problems. What are the areas for improvement? That was one of the first questions I asked. I would ask, hey, what's your top 5 or top 10 areas for improvement? And everybody have different answers. And so, one of the first things I did is start to develop a quality process to look at where the clinical problems work. And they can be a number of ways. When people say what their areas for improvement, people always name, you would say, well, we need some of this, some of this, some of that, Well, my perspective is that what you say you need is just how you feel that your deficits are.
Yeah.
Things you say. It's better looking at other objective data to see what the clinical
and you're
problems
talking globally across the system. You're not talking just what are your problems with ultrasound.
Yes.
You're saying like mechanical ventilation,
Absolutely.
airway.
Absolutely. When we do what was called a needs assessment every year, anywhere we work, we put out a little survey and say, hey, what are the biggest clinical issues that areas for improvement you think you need? Always is ventilation. Every single time people put ventilation every time, because it kind of scares people, especially with the helmets, I guess. And so with everybody, there's always ventilation. And so from that piece of it. What LifeLink a little different is that you guys we have that ultrasound that's there that people should use. And so when I got here, I wanted to look at the QA piece of it. How how good were we, or were we using this in the correct way to get the answers we wanted? And so having no experience in ultrasound, like I would come to you and I said to you to write that book at chapter 4, I had no experience in it.
Yeah.
But as a clinician that's been around a lot of years, I don't have to be an expert in it.
No.
I just need to sit there and just watch it and then ask people, what are the key pieces or key steps that you need to make a decision to do these things?
Right.
And we know from ultrasound is basically gathering an image where you put the probe, the image itself, and then interpretation of the image. Those are two big things.
Oh, absolutely.
Right.
And you don't have to be a pilot to work in air traffic control. You know what I mean? Like,
right.
You can look at it and be like, listen, give me a probe. I can figure it out. I'm sure you've done it enough now, but initially it's addressing the big issue of, okay, we don't feel comfortable. And I would say like the first thing, and the thing that I notice is like, if there's a barrier to getting to that device,
right,
people aren't going to use
Absolutely.
it. If you put it behind the seat in a box behind that netting,
waste of time.
Nobody's going to use it. So what the first thing I noticed we started doing, and it was when our medical directors really started like saying, we want you to use this. Like, it's not something, you can use it. They're like, no, if you're doing these skills, you need to be confirming this on ultrasound.
Right.
And they said, put it in your first, your primary bag. And I don't know who made that decision, but I think that was fantastic.
Right.
To put that in the bag. And it's not this device that you only can use in a helicopter if you have time.
Right.
It's no, take this, use it, bring it into the hospitals with you, because you don't want to be messing on some device that you don't even know about. Use the one that you can record, and we can do that QA, QI. So I thought that was a really important piece of it. The other thing is like the initial education, right? So you go from, okay, here's the views, finding the views. We have, I can't remember what the device we have is.
That we have now?
Yeah, the torso that we scan.
Vimedics?
Yes.
Vimedics.
Yeah. And, it's like, okay, we're learning how to angle the probe at this point. And then you start doing it on people and you learn how much pressure you need to apply.
Right.
And then once you get that down, it's really knowing when you have a good view and when you don't.
Right.
And that's what I thought was a really important part of what you and the education team implemented is the first question was, could you answer the clinical question?
Right.
Because if you're getting a really shitty view of the heart and you're saying, yep, I answered the clinical question, that shows a fundamental gap in your understanding of, it's like getting a chest x-ray. So I can't read that. I can't tell you anything from it.
Right.
And even there are patients you're not going to get a good view on.
Right.
And the ability to look at it and be like, no, I can't answer the clinical question tells you just as much about the provider, the clinician, as if they were to get a perfect view every time.
Right.
Right. So I thought that was really important as well. And then the other thing is this baseline proficiency. And so you guys put out a paper is it this year, 2024?
Beginning of this year, I think.
Yeah, July-ish, somewhere around there, July, August.
Yeah.
Looking at the baseline proficiency for providers and establishing that.
Right.
So tell me the story with that.
Right. One of the first things, when I started pulling the data in ultrasound, I wanted to see who was using it and who were not.
Yeah.
Because some people use it all the time because they're comfortable with it. And then some people, they say, so you being one of the most proficient ones we have here, whoever you fly with is a person I know is a person who's not using it.
You're right.
Because you're grabbing it every second doing it. And they were like, I'm not touching that thing. Tyler knows it like the back of his hand, right?
Yeah.
And so the people you fly with most likely won't have as many images as you are. So what I did is decide to pull a review of images over a certain time frame, say 12 months, and the number of images that people were uploading to our system, to say they were completing on patients. And so when I just got a certain number, and I got every single person, I created a graph of every single person, that number. And so then now I know who's doing them and who's not. So what do I do with that information? And so one is I went to the physician group and I go, okay, I'm not saying we have a problem, but we might have a problem here. We have some people,
discrepancies. Yeah.
Some people who are very proficient at it and some people who don't have any images who are not using it. And so why are some people on one spectrum and some people on the other side of not using it? And I can understand if I'm not comfortable with something, I'm not going to use it as much, And so that's when we came up with the idea of this training method to help people feel more comfortable. And so the first thing there was that ultrasound day. And I think we do that basically, start doing that every year, is to have people come in and demonstrate competency. One thing about quality assurance is that you can't fake, shake, quality assurance when somebody's standing there looking.
With a clipboard.
Dude, exactly. And so like when I do supervised ride-alongs and I get in that aircraft and I sit there, I do that because it is the purest form of quality. I have 37 years experience and you can't fake me. You can't pretend you're doing something. You can't sing words I don't know. I'm going to know it, and every step everything you do, I'm looking to see if that's the standard or what steps can we do to improve it.
Yeah. And it's not like you're looking to ding the individual.
Exactly.
It's looking at how to improve the system.
Absolutely. So that's how we felt with ultrasound. And so we thought if we can have that same kind of thought as people come in and you just demonstrate, we get live patients, students, they come in and you just demonstrate the views. So we have 5 views we do, whatever. And so we have someone stand there and just evaluate the images and you just do it till you get the image you want, the right image. And you say, you got it? Next. Okay. And someone's grading you based on what you're saying is a good image on the student. And so from there, we give you no feedback. You have no idea how you did on initially, right?
It is 1, 2, 3.
Right.
The scoring.
Yes. And so if you nailed it without any assistance, great. 2 is a little guidance,
little prompting.
Yeah. 1 is like, I don't know what I'm doing here with this thing. That would be me. I'm just moving around. I think I see some movement, right? And so from there, people who nailed it out from the beginning didn't go home. When you and others walk in and they do it, they go, oh, it's obviously he knows what he's doing. Boom, you're set to go in 10, 15 minutes of training. The others, however, the second piece of that is, and then we provide those who didn't nail it, we provide multiple opportunities to train. And so we can use the biomedics from, what's the thing in Florida? CAE biomedics, which is great because it gives you it'll give you the normal views. You can see different things. And so we would use that as a way for people to practice. And then we will have other student patients, who would then lay there and allow you to practice on different people, to get the hang of it. And so after you've done it on the sim and you've done it on 2, 3 more times on practice on people, then you come back, right? And you come back and then we ask you the same questions we asked you when you walked in the door. Can you demonstrate, the cardiac views, the lung views, all these things, and people, by that time people got it.
Oh, yeah.
They just get it. And so we understood that once people felt more comfortable, they're more apt to using it. I can remember asking one employee when we were in sim and this person had 0 number of views in this year. And then I had said it to the group, I said, we have people that don't even use the damn thing. And the person that spoke out, I know you're talking about me, when putting it out there, but I knew that she was in the room.
Yeah.
And so this person spoke up, and said, I just don't feel comfortable with it, and so from that point, we created this process of doing it. So now what we require is that we will prefer people to get 75 views a year, and that's from a paper that somebody did from looking at residents using ultrasound to determine competency from repetition, doing it over and over and over again, right? And so what we prefer is people to do them every month, every quarter, to do 3 patients a quarter. And we did it in quarters rather than months. We did it in months, but we know that here in Minnesota and Wisconsin, it's cold. And in our winter months, flight volume
you
is
get some downtime.
Yeah, right. So it's not as apt to be able to get those views. So we put it in a 3 months block. So some months you're busy, some months you're not. And so people are able to get them specifically the summer and the fall. Absolutely.
And that for the clinician standpoint, that just means we have to go get it out of the aircraft,
right?
Bring it into the crew quarters,
right?
And get hands on it,
right?
Play with it,
right.
I mean, just like we would do with airway stuff.
Yes.
Okay, we got to have somebody check us off on this procedure or this scenario, and I think that makes a lot of sense because, it's like the pediatric bag on the ambulance. It's all tagged up. Nobody's gone through it in forever. Right. And then you got to get your hands on it. And then it's like, okay, it's not like a barrier to using it now.
Right.
Like that. And I think that makes a lot of sense. I like the rating system. I would say it's pretty pragmatic. Like you needed a little prompting, you knew it, or you were kind of touching it for the first time, maybe. And that makes sense, and that I would say, like, if you had like your Maslow's hierarchy of needs, or like the hierarchy of learning POCUS, the first thing is just being able to get the view.
Right.
And I don't know, maybe you could say the first thing is knowing when to grab it out, but I feel like we kind of outline when you should grab it out,
Right.
And so with that, the first thing is just getting the view. And then it's like, it goes to the next one. It's like, taking it out, the proficiency of knowing, I guess maybe that would be the second one, is like, I know how to get the view, but I don't know. I jump in the back of an ambulance and everybody's panicking, and there's this guy with a blood pressure of 70/30.
Right.
And it just feels weird to grab the ultrasound out and to do your assessment. But if you're trying to answer a clinical question, and you want to know if he's got a pneumo, it's the right thing to do.
And you were here, and I kind of thought this before I came here and started working with it a lot more. The thought was, what does ultrasound add? Because if someone's in shock, you're going to see them in shock anyway. If somebody has a pneumo, you're going to see them in anyway. And so, and I thought that also prior to coming here, but after looking at it, it's just an adjunct that gives you more information to make a better decision. What it does helps a lot, though, with patient safety is the number of procedures that you normally would do. For instance, pericardiocentesis.
Oh yeah. Just prophylactically,
Right. They have this, and you're thinking it's that, and you just do a pericardiocentesis, right? And so, and I always taught and said to people, the thing about a pericardiocentesis is one of those self-gratifying procedures.
Mm-hmm.
You're going to keep doing it until you get some blood.
Yeah,
it's in there somewhere.
Well, and I remember jumping in the back of an ambulance, and they were getting ready to needle a guy, and I was like looking up, and the SpO2 looked okay, and I'm like, and they're like, yeah, he's really hard to bag, and we don't hear any lung sliding, and we put the probe on, and he had lung sliding on both sides.
Right.
And so they had to suction a little bit. I don't know what exactly was causing it hard for them to bag, but everything else looked good. Right. And so it wasn't that it does validate your procedures, but the other thing is it tells you when not to do something.
Right. Absolutely.
And the do no harm component of it. If I have somebody who's got a pelvic fracture and now I'm just needling him because of my subjectivity of hearing,
right?
After being in a band for how many years, I can't hear anything.
Right.
So it's like pulse checks or whatever. It gives you that objective thing to look at. To say, yeah, I feel safe doing this procedure right now. And so that's where, I feel like when you look at that hierarchy of POCUS needs or implementing POCUS, the very top is like your clinical decision making.
Right. Absolutely.
And knowing if you have the image, do I have the data or the info in this thing that I'm looking at to answer this clinical question? And if not, that's okay. Right. There's other ways we could try to answer that question.
Right.
And it's just one piece of the data. But typically, it's a pretty convincing piece of the data to say, yeah, this guy with a heart rate of 140 and an AFib RVR that they're wanting to give diltiazem to has no ejection fraction.
Right.
And the only thing that's going to do is take away his compensatory rate.
Right.
And I can see that.
Right.
Before, I would be like, yeah, AFib RVR, I don't know, let's give him 10 of dilt and see what happens,
Right.
But it's that thing to go, wow, that is a really crappy EF, the little mitral valve's just barely moving. And you're like, no, that's not a person we want to do rate control on.
Right.
So those types of, in like the OB call, you could see like, yeah, I'm having a hard time seeing the fetal heart rate. But the baby's sucking on his thumb, It's like, okay, I think he's okay. We'll find it eventually.
Right.
So those are the clinical questions that I feel really help. And I would say like and I don't know how you feel about this, but like the fast component of it, it's not really where it shines the most in pre-hospital. Because if you think they're bleeding in their abdomen and they're hypotensive and they just got lawn darted out of a car, we're not confirming that before we give blood. You know what I mean?
Right. Like I think there's maybe a misconception out there. People thinking we're doing ultrasounds before we resuscitate or take care of patients. And that's not by any means. It's an adjunct that you're using to assist you to make a better plan of care.
Now, when you're watching us go through simulation, are you finding now that people are getting more comfortable with ultrasound? They're breaking it out earlier in the sim than we're in the aircraft now. maybe now I'll get the ultrasound and look. Are you finding that clinicians are more likely to pull that out and use it right away?
Right. And Sam, 100%, you see people reach for ultrasound, especially in scenarios, cardiac arrest, people, the LUCAs, the airway, taking care of airway, all that stuff. People grab that ultrasound, as part of that piece to make sure that one is the LUCAs in the correct place and how the heart's doing, that whole thing, and making decisions based on what they're seeing, especially traumatic arrest. And so it's been very valuable. And you see them use it in SIM. Now,
that's what I was going to ask.
However, when I do ride-alongs, I still see people pull it out and use it. So it's not like,
okay, that's what I was wondering.
Yeah, because I always thought in SIM, they see me standing there and they go, I know he's looking at that. Let me pull this thing out. By me doing the ride-alongs, that just helps me validate what we're seeing in SIM. It's the same thing that's happening in the field.
So they correlate pretty well.
Oh yeah, especially for ultrasound. Yeah.
Yeah, I typically find like if we're doing an intercept or something, and you got the person that's going to go in through the airway, the side door. One of my first things is getting the ultrasound out. I'm just putting it on, looking at lung sliding, talking to the patient.
Right.
But it's an extension of that physical assessment. And if you're waiting for the right time to pull it out, you're going to be waiting for a while. You know what I mean? Because you're going to sit there and you're like, okay, maybe we can do it later. I got to do this right now.
Yep.
And then you look back and you're like, you know what? I had time.
Right.
Like it was my perception that I didn't have time to go through that.
Right.
And so, that's what I was curious is in SIM, because I feel like in SIM, it's the quickest way to get through a SIM. You're like, do I have lung sliding? No. Okay.
Right.
All right, we're going to call this a pneumo then at this point.
Right.
So what do you see, like the horizon of us maintaining this proficiency? We use a API, I don't know I guess that's what you would call it with Protean right now for QA, QI.
Yep.
You guys have ultrasound reviewers in play.
Yep.
So these are like subject matter experts that are peers that review it. And then we have our medical directors that review it as well.
Right. And so that process, Angie Techmeyer, part of her project for her thesis for her master's, wanted to create a look at a program like that to have the subject matter experts to do that. So I think every 2 bases, we have somebody just to review them, right? For that group, what it does, it makes them eventually a super user. Because now we have about 4 years now, almost going on 4 years, that this group has been doing it. So they get
wow, it's been that
long. It's been that long. Yeah, been doing this. So they're pretty proficient at grading their colleagues' ultrasounds. That's what they're doing. The physician, however, Dr. Peterson, and the main Dr. Peterson, he's responsible for making sure these subject matter experts are doing the correct thing. So we do an audit of a certain amount every quarter of images that the subject matter experts have done to make sure that they've read those correctly. So somebody's auditing the auditor. And so we do that every year as part of the quality check to make sure they know what they're doing. Other thing we do for those subject matter experts, we give them education beyond what you guys get. And so the staff gets the education we put out every year regarding ultrasound. We send these guys every year somewhere to get something
phone frat.
Yeah.
No, exactly. No, yeah. Like this to do extra learning on
exactly. And that might be one who has a course at Regions they had, the Hennepin course. I'll try to send them something different. It may not be perfect for air medical, but you can, like when me and you went to the Hennepin course, I didn't know what the hell I was doing.
Dude, the speckle track.
Oh yeah. Cause it was
we had to opt out of the transvaginal.
Oh yeah. I'm not doing it. All those different parts of that course, cause it was mainly geared to emergency room.
It was, physician.
And I was like, this lost. Cause I was brand new.
Yeah.
But I was looking at it from a perspective of how do you QA all of this kind of stuff?
Oh God, yeah.
And so by sending those guys to something outside of their comfort zone, something they're doing, you're able to pull out the stuff you need, even though it's not necessarily for you. You can do that. And so that's what we have those guys, those subject matter experts, do that. So that's been pretty successful. The team that does that seems to like it. We haven't had a lot of turnover with that group, and so they give feedback obviously to the clinician who submits it. So you're able to see what they thought about your image. Now,
do the medical directors look at every image or just the ones that get escalated?
He gets the ones that's escalated by the subject matter experts.
Okay,
when they're like unsure, or they may say, you probably need to look at this one. that was something really, really great that he wants to show.
Either related to the image or the call.
Right, exactly. You probably want to look at this. He
Yeah.
gets those, absolutely. They forward those straight to him. And then he does an audit of a certain percentage of each of the subject matter experts. So it's not every image, not by any means. So I say not every image because we're past that point. Maybe the 1-2 year part we were doing it, he was probably looking at a lot of images, and then got to a point where, okay, I would do the QA on his review of those 2 years of each individual, and everybody was in that 95 a graded percentile. Everybody was way up there as far as evaluating those images correctly. So once you do that for 2 years and you kind of got the team in place, then you can kind of back off a little on the QA, only do another certain percentage of it. Say just 15% of the images that they do as a number.
Yeah, I think with a big organization, that's probably a very necessary thing to do, is to have subject matter experts. And also you can utilize those people to teach and onboard when somebody's first coming on and learning the process. Because if you're trying to learn how to do fractional shortening and E-septal separation on the first day, it's like, I just need to know how much lube to put on or gel. I guess gel sounds better than lube.
Exactly.
But I just need to know how much gel and pressure to put on there. Right. And those are like the very elementary things of learning it.
Right.
So are we collecting any data right now to look at our true positives, true negatives, for accuracy?
Not really. We haven't had in the past, 4 years we've been doing this, we haven't had any major issues with it.
Yeah.
With people
interpreting.
Yeah, maybe once. The subject matter expert says, "Oh no, that was this," and they said it, wasn't. So maybe like one like that. So we had to occasionally have that kind of thing.
And maybe that was the wrong way of asking. Maybe more so like how it's impacting clinical care and patient outcomes.
Oh yeah, I would say is one, like I mentioned before, the number of procedures like paracardocentesis that's guided by ultrasound, much better than before. Yes, before you do it blindly. And then also the number of procedures with needle decompression. When you have no lung sliding, you use that as, I have a pneumo, but do I have a tension?
Yeah.
And so you just use that to add with the others to say, yes, they have a tension rather than something else. So it's been very valuable in that because, related to outcomes and identifying those. As far as bleeding, per se, we talked about having a system where that we wanted that when clinicians would do ultrasounds and they said the patient had a positive belly, communicate that to the hospital they're going to. And so
go right to the OR.
We'll go right to the OR to see that we could create a system that we could do the abdominal ultrasound. What's the word?
The right upper quadrant?
Right upper quadrant. Yeah. That spot. I do these a lot.
The belly. The tummy. Yeah.
Exactly.
They got a hot belly.
Exactly. Hot belly. And so taking that information, sending it to the hospital and say, hey, we have a hot belly. And so they would be so comfortable with us. They would, patient go directly to the OR. That's a big deal.
It is, yeah.
Because, the set up a room, open trays in the OR, that's a lot of money.
Oh, yeah.
For you to roll in, they go,
oh, that's ascites. Yeah,
exactly.
Or you clown, that's the gallbladder.
Exactly.
Yeah,
exactly. And I think a program in Houston has it like that, where they do that and able to go to the OR. What's the program in Houston? Houston, not HC. Not HC.
I was going to say HCA.
Not HCA hospital. It's Houston. God, it's a nice program.
Probably got a star in the name, right?
Yeah.
Star something.
I know, but they have something set up like that. So I would love to get something like that here, but it's hard to convince people because, once you get to the ED, it takes seconds for them to get a probe, put it on the belly and go.
Yeah. And that's,
that's the tough part.
That's kind of the same argument. You could argue probably less expensive, but for taking someone to cath, with the 12 lead.
Yep.
Where they'd be like, stop in the ER real quick.
Yeah. Same thing.
How much proficiency do you have in that? But you have to really, the hospital has to trust the EMS.
Right.
And I remember like where we used to, on the ambulance, transmit our 12 leads in order for them to do it. Now, you can't really transmit it
Right.
flying. But who knows what that looks like in the future? How much time that actually saves to go straight there instead of stopping in the ED first, because they're probably going to want to start giving some blood and stuff there. So no, I could see that. I think like we're already going to a level 1 trauma center, typically level 2 or level 1. If we're flying them, we're not taking them to something lower than that.
Right.
And at least they're at the facility. We're giving blood. We're doing the stuff that we think the TXA or whatever.
Right.
So I could see that. I just was curious because, still at this point, to the best of my knowledge, like insurance doesn't reimburse for ultrasound. It's it's just something we use to help with our clinical decision making, but we're not able to really charge for it.
And that's the sort of problems with healthcare. EPOC that we use for labs and ultrasound and whatever anything extra that you do for your program or for your patient care.
It's all under the umbrella of
transport. Yep. Which is kind of crazy. That's why all programs aren't created the same. People, they look at it as they're all the same. They're not the same. Really not the same.
Awesome. Well, any parting advice or any wisdom to somebody who's wanting to implement this into their program? Anything we didn't discuss?
Yep. I would say one of the big things is for the future, for people who want to implement it, I would say, if you could, to help as you create your program, is go with a product or a system that has AI. And so, I'm sure most of these products are moving to AI, which helps people make decisions. So for somebody like me who has zero experience doing that, imagine how that helps me as me putting a probe on and it's saying, probe's upside down. Or this is the left ventricle. It's telling you what you're looking at that helps you make the decision. So that helps with training. If you can have AI can interpret what you're looking at and kind of help you do it. Maybe not say, that's an effusion or that's a tamponade or this kind of thing, but just tells you the different structures. That'd be helpful.
Have you used one with AI?
I've seen it. I can't remember the company that showed it to me.
There's a couple. There's like Echo News is one, and then there's a couple that have it. So for me, when I played with that, I felt like I liked it for learning.
Right.
But I wanted the ability to turn it off.
Right.
It's like a GPS in your neighborhood telling you to make a U-turn, and it's like, I want it for learning. But I want to at least have the ability that it's not going to impede or get in my way when I'm trying to knock out an exam real quick, But I agree that the AI side of it, I think, is important in even the education part of it.
Big part from that, the education piece. And the other thing with creating a program, is that if you do it, especially like big companies, the AMRs, the GMRs, and the Air Methods, those really bigger companies, that takes years to implement to get a program going like those. And I would caution anybody is to do it in the small segments.
That's what I feel like you see that. Like, we're just going to do a couple bases.
Yeah, a couple bases to get them proficient in it. And then you get some subject matter experts, and then you just start moving it out to be bigger and bigger things in it. And the key thing is that it just decreases the number of procedures you're doing that you're maybe not necessary for you. And two, it just gives you more information for you to make a decision, on these patients that you're kind of borderline. You're like, okay, I think this is it. Let me give this, and boom, there you go. So for instance, somebody's bleeding. Bleeding can only be in 5 spaces: street, pelvis, long bone, abdomen, thorax.
Yeah. Yep.
And so if you're going through those, this helps just guide you on 2 of those, So
no, I think that's great. Does LifeLink, let's say somebody was like, we want to learn this. I want to pick Allen's brain on it. Or some, within LifeLink, do they offer anything? They're like, we'll talk with you and tell you what we're doing.
We've had people reach out to say, hey, how do you, implement your program? A lot of stuff we turfed to from
call Tyler.
Exactly. It's, to be honest, it's not a lot of companies or anyone out there that can come in and say, okay, do this. We can only tell you how
the demographics are so different.
Yeah. And then you can see people want to use it, and people have to have knowledge of it, but it's getting the people who are responsible for the purse strings to purchase it, And
Yeah.
and I said before, the key thing, if you don't have a quality assurance program, don't you dare put down the aircraft for somebody to kill somebody.
Nope.
No.
Yep. If they're just sitting in a tablet somewhere, on your
Right.
ambulance, you know?
Right.
And that's, so I had this talk called Implementing POCUS, and it's like, I can tell you, like, from a clinician standpoint, what I think works.
Right.
But that's where I wanted someone who's looking at this as a system for
Right.
you, because I have not been in a leadership position and said, hey, we're going to implement POCUS. You know, I don't
Right.
have any
Right.
expertise in that area at all. And so that's why I thought maybe, you know, this conversation may bring some light to like both aspects.
Right.
And what it looks like from somebody who's looking at the entire system versus somebody who's going, hey, I'm really glad it's not in the box behind
Right.
the forward-facing
Right.
seat anymore,
Right.
you know?
And that's part of it. When I came here, I said to Dr. Fresco and the docs, I said, I just want to say, I have no idea what they do with that ultrasound. Whether we're doing it right, wrong, I cannot tell based on what we're doing. So I want to just redo the whole thing, you know, and they're
Yeah.
like, let's do it. I don't care, you know. And so now we're very clear of where we are, you know, and it's like 95, 98 percentile. I think it's 98 percentile. This last one like that of accuracy of that thing.
Yeah,
That's
great.
fantastic. And then people who were not comfortable after going through that training now are comfortable. Once you're comfortable, don't you know, you don't want to lose it. You know what I mean? So do it over and over. So it's like getting a teeth cleaning. You want to get a teeth cleaning, you know, once every 2 or 3 years. You want to do it every year. So it keeps it.
So that you don't have to get the cat. I know too much
Exactly.
about that.
Exactly.
Awesome,
dude.
man. Well, thanks so much, dude. I appreciate it.
Absolutely.
We'll put your email and stuff in the show notes, your personal cell phone number, the address to this nice place. You have a beautiful place, dude. This is awesome.
Thank you. A lot of wonders.
Thanks, brother.
All right, man. Thank you, dude.